This conference will now be recorded.
Good morning. I'm Dr. Anjana, one of the doctors in antenatal clinic today. Can I confirm your name, please?
Hello,
Hello.
doctor. I'm Andrea Rollins. I'm 27 years old.
Okay. How do you like me to call you?
Can you call me Andrea?
Hi, Andrea. You can call me Anjana. I have got a letter from your GP that you're 11 weeks pregnant. So,
Yes.
is this a planned pregnancy, Andrea?
No, actually, I was on oral contraceptive pill, and just recently I learned that I was 11 weeks pregnant, and obviously it's a pill thing.
Okay. So, how do you feel about this pregnancy right now, Andrea?
I'm okay with it. I want to continue with it.
Okay, then. Congratulations on your pregnancy, then. So what I have with me is some set of investigations that your GP has done. Has it been discussed with you before?
No.
Okay. So today what I'll do is I'll ask few questions to you, and then I'll discuss your reports as well, and I'll discuss your antenatal plan with you. Is that okay, Andrea?
Yeah, sure.
Okay. So can you tell me about your periods? Are they regular?
Yeah, I have a regular period every day cycle.
So your last period was 11 weeks back, right?
Uh, Actually, I don't remember. Now I'm 11 weeks pregnant. I don't think it's relevant to.
Okay. Can you tell me about your smears, Andrea?
Uh, I think I took a smear 2 years back, and that was normal.
Okay. So, are you living with someone right now?
Yeah, it's been a year since I'm living with my partner.
Okay. So, how does he feel about the pregnancy?
Yeah, he's supportive. He's good.
Okay. Is there any history of sexually transmitted infections, Andrea, in the
I
past?
don't think so. No, I
Okay.
don't have it.
So you said you were using contraception and you got pregnant, right? So can you tell me what
Yeah,
contraception you were using?
I was using an oral contraceptive pill.
Okay. So were you regular with the pill or did you miss pills in between?
No, I was regular.
Okay. So, did you have any vomiting episodes, or did you uh, uh, take any of the medications along with this pill?
No, I don't have any allergies or vomiting sensations.
Okay. So, can I ask, do you have any other medical comorbidities? Like, is there any other disease that we should be?
மார்னிங் உங்களை கூப்பிடுறது எனக்கு கஷ்டம்னு
No,
தெரியும்.
nothing. I
Okay.
don't have any conditions.
Okay. What about any surgeries in the past?
No, nothing. No surgery.
Okay. And any families disease that we should be aware of?
I don't think so. I don't have any issues.
Okay. And what about, do you smoke or drink alcohol, Andrea?
Is it relevant? Yeah, I
Um,
do. I do smoke.
yeah, and actually, since you're pregnant, I just wanted to ask about the history to you. So, you smoke?
Yeah, I do.
So, can you
I
tell
have
me how?
20 cigarettes a day.
Can
20
you tell me how?
cigarettes.
Okay. Andrea, at this point, I'll tell you that smoking can be harmful for both your health and the baby's health right now. Have you ever thought about quitting smoking?
No, I've not never thought of quitting smoking at all.
I understand it might be difficult, but what we would strongly recommend is for a pregnancy to go well, the mother's health should be optimized, and cutting down smoking will always help for a healthy pregnancy. There are
Uh,
chances that because of smoking, the pregnancy the baby can have become can grow small or it can't reach the correct size, and there are chances that your pregnancy can end preterm, or there are chances that your afterbirth can separate from your womb before your labor. So these are all the risk factors of smoking. So I strongly recommend that you stop smoking, and for this, I'll put you in contact with some support groups as well. Okay, there are NHS stop smoking services to whom I'll refer you to. Okay, is that okay?
okay, but should I actually totally quit smoking or can I cut down, try to cut down a bit
You can
first?
try cutting it down. They will be giving you a lot of options as well. So, in which the toxic nicotine level will be reduced. It might be beneficial to you. Is that okay?
Okay. I don't know whether I'll be able to quit smoking all of a sudden, but will these support groups and whatever you tell will help me?
Sure, you can talk to. I'll give you some websites of mothers who had gone through the similar situations. It's a 12-week program that these support groups take, and they might be able to help you out. Okay.
Okay,
Do you
done.
take any drugs, Andrea?
Yeah, I do.
Okay. So, and what about alcohol?
Yeah, I do. I have 3 shots a day.
Okay. So, what we have to do is, as I told earlier, even alcohol and drugs can have side effects on the baby. So, I understand this must be overwhelming to you, but then I would give you some support groups to whom, if you talk, you'll feel better. Okay.
Hmm. So I should
Ever
quit alcohol also.
actually, you can cut down alcohol, and in pregnancy, the recommended dosage will be very less, around 3 units per week. It'll be like half a pint of beer kind. So these doctors will be helping you out. Is that okay?
Yeah, okay. Thanks.
Have you ever shared needles, Andrea?
No, I've never taken any insurance. I just have a little bit of coke and none. That's it.
Okay. So right now, what I'll do is I'll just your investigations, like your blood group is O positive, and all your investigation like hemoglobin, your urine culture, and your scan report seems to be normal. The pregnancy is doing well right now. Okay, so
Okay.
congratulations for that. So I'll just tell you the management plan and natal care. Okay, so you'll be advised to take a Downs screening. Um, that is between 11 to 13 weeks you'll be offered a genetic screening for the baby, and between 18 to 20 weeks you'll be asked to take anomaly scan. These scans helps to know whether the baby is growing well and whether it has right growth, and we'll be putting you on folic acid and vitamin D in the first trimester, and will be monitoring, your midwife will be monitoring you, and she'll be making sure about your smoking, whether you're able to reduce the smoking and alcohol levels as well. And at around 28 weeks, we'll be doing another scan, that's a growth scan. And uh, and the further plans of pregnancy or mode of delivery, everything will be discussed at around third trimester at 37 weeks of gestation. Okay, so if everything goes on well and if you don't have any problem, then vaginal delivery is not contraindicated. We can go for a vaginal delivery, and the detailed delivery plan will be. It's too early to discuss about the delivery plan at your term. I mean, we have to see how your pregnancy course, pregnancy takes its course, and then we'll be discussing about that in the later trimesters. Is that okay?
Doctor, what do you think about this e-cigarette? Can I use an e-cigarette instead of actual cigarette?
What, can I use what?
E-cigarettes?
E-cigarettes can be used, but still it has some amount of risk associated with it. There can be other replacement nicotine replacement patches like that, which record says that can be used in pregnancy.
Hmm. Okay, fine then.
Okay. Is there one more slide, Doctor?
Yes, yes.
Good morning. I'm Dr. Anjana, one of the doctors in colposcopy clinic today. Can I confirm your name and age, please?
Doctor, patient is not there. I just want to discuss about sharing, doctor. I'm Kelly.
Okay. Uh, Hi, Kelly. I'm your ST5. How are you doing today?
Hi, I'm doing fine.
Okay. So I understand that you wanted to discuss about the colposcopy finding of a patient. Is that right?
Yes, yes.
Okay. So how is the work going on, Kelly? How do you find the unit?
Yes, it's fine. See, just now I joined this colposcopic training because it is part of our
Okay.
GP training. Yeah. But I'm little worried, like what to say to Sarin. Though I know all the information about her, but I could not say what exactly because even I don't have much head about colposcopy, how it is done, how to interrupt this colposcopy finding. So I could not say anything to her.
I understand, Kelly. We all went through the same. Like we all had this confusions, and we all had a lot of discussion with our seniors also. Okay, so
Yeah.
can you tell me, have you read about the colposcopy findings before?
No, not much. Just a second day of my training today.
Okay, I understand it. It's very appreciable that you have so much of enthusiasm for learning. Okay, so what are your expectations from today's topic, Kelly? Like, is there any particular thing that you want to learn?
See, I want to know how the colposcopy done and how to interpret the Seren's findings. So what to convey to her.
I understand. And we'll be covering all that. Okay. So
Yeah.
what I'll be doing today is I'll be telling you when to do a colposcopy and how to do a colposcopy and what to see from a colposcopy, and we'll discuss about her results also. Is that okay? Doctor, patient Saren's results. Is that okay?
Yeah, yeah, yeah.
Okay. I'll ask you some questions in between to know what you know also. Is that fine, Kelly?
Yeah, that's fine, fine.
So since you're working in colposcopy clinic, what kind of patients did you see getting referred over here?
See, the normally after the smear, if something is abnormal, we do get referral. So based
Yeah.
on this, they are referring for colposcopy. Yeah.
Exactly. There are some conditions where, like, if three smears are inadequate, or if it's a mild dyskaryosis with their HPV positive, or if it's CGIN, or if it's severe dyskaryosis, in all these patients, the GP usually refers to colposcopy for further knowing about the condition, right?
Okay. Yeah.
So what is a colposcopy? What have you seen about the machine? How do they do, Kelly?
See, I know some light sources is passed and we can magnify and see the cervix. That's I know, but I don't know something they apply and what exactly they see, what magnification. I don't have get much idea.
Exactly. Well done for your observation, Kelly. So what we do is we magnify the cervix and then we see it on a screen, and then we even apply some green filters to see how the cervix is looking. Okay.
Okay.
So and we also apply the solutions you said that we apply are two things, that is 5% acetic acid and Lugol's iodine. Okay. So these are
Okay.
the solutions which picks up any lesions apart from the
Okay.
normal cervical texture. Okay. So we
Okay.
apply 5% acetic acid and we wait for a minute, and then we see if there are any white areas, patchy
Mm-hmm.
areas, and we apply Lugol's iodine, and we see if there are any difference in the color apart from the mahogany brown color. Is that okay? So
Okay.
these areas will identify the places in the cervix which are abnormal, so that if at all we find such an area, we can go and biopsy that area. Okay,
Okay.
so from the biopsy result, we get a more clear picture of what is there in the cervix. Right, so there is a score. We have some sweet score, read score, and there are scoring systems from observation of these cervix also. Okay, so
Okay.
these scoring system will I'll give you some sources for you to read these scoring systems. But the overall gist of this scoring system is it will take into consideration whether the transformation zone in the cervix. Are you aware of transformation zone, Kelly?
No, doctor, what is that?
Okay, so there is endocervix, there is ectocervix,
Okay.
and there is a meeting point in between. So
Mm-hmm.
this zone should be visible for a colposcopy to be seen clearly. To say that this colposcopy is satisfactory, this zone has to be visible. So in colposcopy, we see if this transformation zone is visible, and and we see if there are any abnormal blood vessel pattern, like any mosaic pattern or punctations, or if there is any dilated blood vessels. And
Mm-hmm.
we also see the finding of these Lugol's iodine and acetic acid. And together we grade, and together we decide, along with the biopsy, what the patient is having. Okay.
Okay.
So right now, I understand that you have the patient's finding. So can you tell me I mean, can you tell me what the finding is?
I don't think, doctor. It looks like some. I don't know what exactly to interact. But I got information from Sherin. She has been referred not for an abnormal smear actually. She had a bleeding after sex, postcoital bleeding. So she has referred to the gynecologist under 18-week wait period. And the gynecologist suggested because the cervix is looking something abnormal for colposcopy.
Normal. Yeah.
Yeah.
It could be could be two, three differential diagnoses for it. It could be an
Mhm.
ectropion, or it could be a cervicitis, or it could be a cervical malignancy.
Okay.
It's erosion or ectropion. All these are not the inflammation of the cervix, and cervicitis is might be because of any infection in the cervix, and of course you'll be aware of cervical cancer, which might be the change in the abnormal cells going through the different layers of the cervix. Okay, so we need to biopsy the cervix, and we need to see what her pathology might be. Okay, and depending on the biopsy report,
Does
we
she
have to
need
decide
does she
whether we
need a biopsy now, doctor? What should I tell to her?
uh, yeah, we need to take a biopsy to rule out cervical cancer. But most probably it looks benign and it looks like a ectropion. Okay.
What is ectropion, doctor?
It's kind of like a inflammation of cervix, and it's outpouching of the internal lining of the cervix.
Okay,
Okay.
okay,
So the other, she might require a small procedure like cryotherapy or heat cryotherapy or any laser, or she might require a biopsy from the region, which we call it as like LEDS procedure, excisional biopsy.
okay. So, should I ask anything from Sharin? I just asked her
We have
whether
to
she had
ask.
any other problem. Yeah.
We have to ask what is her age? What, is she planning for any other pregnancy? And
Mhm.
she might need to come for follow-ups also if we find any abnormality.
Okay, okay. I should ask these questions to her. Okay, doctor.
Yeah.
Now I should
We have to
tell
ask
her.
about
Yeah.
a previous smears. She's 36. A smear should have started by 25. So we have to ask what her previous smears were,
Mhm.
and any other previous surgeries in the past.
Okay, okay,
So if it's just a cervicitis or ectropion, we just have to give her a dose of antibiotic.
okay, okay, doctor.
Yeah. And can you tell me what you understood, Kelly, from colposcopy?
Yes, doctor. It is with help of the green filter. We are looking into this cervix with a magnification, and we are using iodine and this. What else you told? Iodine and acetic acid, correct? Just to see and look into the abnormal cervix.
Okay.
Hello.
Hello. Uh, Good morning. I'm Dr. Anjana, one of the doctors in infertility clinic today. Can I confirm your name
Hi.
and age, please?
Hi. This is Paul, and I'm 30 years old.
Okay. Kindly call me Anjana. And how can I help you today?
Actually, I just came in to just know about the results of the samples we have given. Thing is, like I and my wife Jessie, we have been like dying for a baby for more, like approximately more than 2 years, like 6 months,
Okay.
maybe, and we're not succeeding on uh, despite things are all fine between us, like still there is something lacking. So we just wanted to rule out: is there any medical conditions that is
Yeah.
hindering thing on?
I understand your concerns, Paul. So, what I'll be doing today is, may
Mhm.
I ask where your wife is actually?
Jessie is not with me. I didn't want to take her here because like she's a little more sensitive. So I thought like let me get the things known first and speak to her like whatever it is.
Yeah, we would like to
Uh,
tell that we maintain confidentiality of both husband and wife's report. But if
okay.
in case you both are comfortable coming together for consultation, we would recommend that as well because it will be easy for one partner to understand the other partner during these counseling sessions. Is that okay?
That's all is fine if all the reports are fine. Like, but let me at least know. Like, if things are normal, then no problem bringing her here. But
Okay.
like, if something is inappropriate, then I think like let me know first so that I can put it to her in a
Okay.
way that she can take it. Because she's already down with the thought that like already it's been like so long she's trying for a kid and like she's mentally very upset that we couldn't get a
I
baby out.
understand. I what I'll do is I'll ask you a few questions to know more about you, and then I'll discuss the report with you, and then we can I'll tell you the available options. Is that okay?
Oh, that's really fine. That's really good. Like if he could help us or something out to bring on like a kid, yes, that is what we wanted, and we are always ready to go with whatever you say.
What do you do for a living, Paul?
I work as a salesman, running around doing all my marketing works. Uh,
Okay,
so it's kind of a roll around job running around the city.
okay. So part of my job is to assess your sexual health as well. So I need to
Okay.
ask you personal questions. Is that okay?
Yeah, I'm pretty fine on like any questions you ask. Like, you can go on, no problem. I couldn't hear you, ma'am. The voice is breaking.
Not audible, Dr.
Hello?
Anjana.
Yeah, you're not audible, ma'am.
Yeah, I have just passed her timing. Let her join. Dr. Anjana can't hear you. No, we could not. We could not. Yeah, now please talk.
Yeah, I can hear you.
Yeah, I have
Yeah,
raised
yeah.
her.
No, what?
Yeah.
Yes.
So can you tell me about your sexual life? Is there any problem?
Not really. We are pretty fine with our social life. Like, we don't have any issues.
Okay.
Like, we make out like around like at least 2 to 3 times a week, and it all goes pretty fine.
Okay. So have you fathered a child before in any other relation, or is this the first time you're trying for pregnancy?
No, I haven't. Like, this is the first relationship I haven't. Just this the first one.
Okay.
One.
So any issue of medical conditions that we should be aware of?
About me, I don't say nothing to put in the box, but like, yeah, I had a surgery around like 8 years back. Like, I had an appendectomy done.
Okay.
That's it. That's the only thing that it's
Did
from
you
the
have
medical
any
records.
surgery or trauma in, especially in the genital areas as a child or before?
No. Not at all. Nothing of that sort. Like,
Any family history of genetic condition that we should be aware of?
no. Like all the family ancestors were pretty fine. Like they were going on with like
Okay.
good number of kids they have. So that's
And
always fine.
are you taking any drugs or do you have any allergy to drugs?
I'm not on any regular medications, no, not at all. No, and
Okay.
allergy, as of I know till today, like nothing more. Like I just go with the medications the doctors prescribe me during some cold, cough, fevers, like those, like very occasionally. And
Okay.
I have not noted any allergy.
Do you smoke or drink, Mr. Paul?
I do smoke. I do smoke almost like maybe I can just calculate like 4 to 5 up an average cigarettes per day. Drinks as such, I would say it's very occasional. It's like kind of a social benefit. Working in this profession, I have to meet with some clients. So,
Sorry, my audio was lost. What did you say?
no, drinks as such, it's very occasional. Being on this professional, it's kind of a social drinking. That's it, on
I
weekends or
understand.
something.
So, while
Smoke
trying
is
for
like
pregnancy,
4 to 5 cigarettes per day.
okay, while trying for pregnancy, I would recommend that you cut down those cigarettes also because it might have an effect on your sperm count and the quality of the sperm. Is that okay, Mr. Paul?
I've been doing it, trying for a long time, but the stressful job running around like
I
see
understand it
that
might
for
be
one of the
difficult for
step
you
was
to
just like yeah.
it might be difficult for you to do it alone, but I'll put you in contact with NHS Stop Smoking Service. They will help you around with that. Okay?
Oh, if someone can bring me out, that will be really helpful. Yes.
Yeah. And any other? I'll discuss the findings with you, Paul. And seeing we got your semen analysis. I'm really sorry to say that yeah, in semen analysis there is a abnormality that is picked up, and
Huh?
is the number of the count of your sperm and the size or the shape of the sperm and the speed of the sperm is less than the normal call. We call this condition as oligoastinospermia.
So why I couldn't get it? Like you mean to say that the problem is with me, and that is the reason for not having a baby? Like,
We can't put it that way. I mean, we need to, if we correct this, there is a possibility for you to get pregnant, higher chance for you to get pregnant.
okay. Like so,
Okay.
thing is like so all these days it was me the cause behind. Like
It's, did you have, just don't mind me asking, did you have any mumps or any infections that in your childhood?
um no. To my knowledge, I don't know. I had to just check out with my parents. Like, remember them telling me anything on this.
Okay. And did you take any, I mean, bodybuilding, for bodybuilding, do you take any drugs or anything?
Yeah, I do work out. I go to gym. Like it's like and the past 6 months I'm consistent with the gym. And one of my trainers suggested me a protein powder, and I've been taking it recently. Well, I've been taking it.
Okay. One of the reasons for the deranged parameters is because it could be the protein powders would sometimes will have testosterones, and
Okay.
yeah, if external testosterone is given to the body, then the body's supply of testosterone and can come down. Okay, and
No, okay, okay. But like, let's see, I asked my gym trainer. He said like many of the people are taking this and they didn't have any issues. So that's how they gave me
but
this.
when you're trying for pregnancy, it's better to stop all that. And what I would
Okay.
advise is we'll do one more test, semen analysis, 3 months later. And we'll also have to do some hormone tests apart from what is done. And we'll do a scrotal scan as well to see whether everything is fine. Okay. So
Yeah.
with that, we'll see if we are getting pregnant, or I'll just discuss some options, especially because the sperm count and numbers and everything are less. If it continues to be like that in future, I'll just tell you there are other options as well. Do not be worried. Like we have artificial insemination, or we have IVF kind of options where the best fertile sperms of yours will be transferred into your wife. And there are options where we can even inject a single best sperm inside the womb of the ovum of the produced from your wife in a laboratory, and then we can insert the fertilized egg back into the womb of your wife. So there are a lot of
No, no,
options.
no. Yeah, I'm like, see, I couldn't get it, ma'am. Like, you say that like the sperms are not coming out, and you're saying like you can take a sperm and put it into the wife. The like, I couldn't figure it out, man. So you mean to say there is no sperm in the semen, like, and then you
Time is
also
up.
say that, yeah.
Time is up.
So this, you know,
Uh, can I go for the next question?
One page.
Is there any other page, ma'am?
No, no.
Good morning, I'm Dr. Anjana, one of the doctors in Gynec Clinic today. Can I confirm your name and age, please?
Yeah, hi. I'm Mary Joy.
Uh, your age?
Yeah, I'm Mary Joy. I'm 45 years old.
Okay. And can you, how do you want me to call you?
Yeah, you can call me Mary.
You can call me Anjana. Hi, Mary. So
Hi.
can you tell me your complaints?
Okay. See, I have irregular periods. Like in the past 6 months, my periods is not regular. It used to be regular earlier. So now it happens sometimes between 40 to 60 days, which I'm not able to predict. Uh, and it lasts only for 2 to 3 days. I'm also getting some hot flashes during my periods.
Okay, so what I'll be doing today is I have your results, Mary. I have confirmed your name and NHS number in the results. And what I'll be doing today is I'll ask few questions to know more about your condition, and I'll examine you once, and then we'll discuss about your management plan. Is that okay?
Yes, doctor.
Okay. Apart from this hot flushes and irregular cycles, do you have any other problems? Can you tell me about, especially about your sexual life? Are you with someone right now, Mary?
Yes, I mean, yeah, I do have my partner, but yeah, I'm little not interested. Like I'm getting some irritation and not getting into it.
Okay. And do you
Have some.
feel painful during your sex?
It's not painful. Like I feel it's very dry and
I
yeah,
get
it's
that.
a little discomfort. Yeah.
Okay. And what can you tell me more about your smears?
Yeah. The last smear test was. I mean, there's no problem there. It's all good.
Okay. Have you
So,
ever been pregnant before?
yeah, I do have three children. I mean, it was all a normal delivery.
Okay. And do you have any medical conditions like migraine or do you have anything that we should know of?
No. We don't. I don't have any other problems right now.
Okay. And have you underwent any surgeries in the past?
No, doctor.
Okay. So, are you on any medications right now?
No. I mean, you asked me earlier, right? I'm not taking any medicines now.
And is there any allergic history to any medication?
No.
Okay. And whom are you living with, Mary?
With my husband and three kids.
Okay. So, is everything in the home supportive? Is everything okay at house?
Yes. It's all good. Good at home.
Okay.
Yeah, it's all good at home, but I frequently get this mood fluctuation. Sometimes uh, I I mean I shout and at my workplace also like I'm shouting at my colleagues. It's basically not sure because of this problem, but yes, I do have some mood fluctuations and I'm little not comfortable.
I understand, Mary. And don't mind me asking, do you smoke or drink?
No,
Okay. So, Mary, what I want to do is I want to
I
examine
don't
you in
smoke,
presence
but
of.
I mean, I drink excessive amount of coffee. Like I take 5 to 6 cups of coffee uh, per day.
Okay. Okay. Um, so maybe what I'll be doing is I'll examine you in presence of chaperone. I'll take your BMI and I'll take your vitals. I'll examine your see your abdomen and I'll examine inside also, internal examination also to just see how things are. Okay, and
Okay,
then I'll discuss with you the results that was taken and then I'll tell you about a plan. Okay.
sure, doctor.
Okay. So, confirming your name, age, and NHS number on your result. The results, which was taken, was hormone test. It shows your hormones that are secreted by the brain for good functioning of your ovaries and also your thyroid hormones. So, all the three test reports are normal.
Okay.
Okay.
Mm.
Um, and your symptoms usually is very similar to what a menopausal women feels. Okay, Mary. So, have you heard of all the menopausal symptoms, or have you heard about menopause? What it does to a
Uh,
woman?
yes, like after 45, like where the period stops, right? I mean, am I right?
Yeah,
Fine.
yeah. So usually you might be in the menopausal transition phase where
Okay.
that's why you're getting irregular periods, and in a menopausal women will have loss of sexual interest. They might have vaginal dryness, and they might feel sexual activities painful, and they also might have problems remembering or they might be angry throughout the day, and all these are what normal female goes through. Okay, and they also have this kind of hot flushes. So one of the problems over here is from your history I can see is because of your age of 45 years, usually the time a female goes in for menopause will be after 50 like that. But right here, you might be in a transition phase for menopause. Okay. Um,
Okay.
what I'll do is I'll put you in contact with menopause clinic. I'll also put you in contact with counselors. I can see that you're struggling to cope up emotionally, so they will help you out in coping up with this. Okay. And as for each of your problem, we'll address it separately. Like you said, you had vaginal dryness, you have problem in sex, and for that, we'll give you some lubricant cream or estrogen cream that can be applied in your vaginal area, and that might be a solution for this dryness. Okay, and
Okay.
we need to wait till your periods might be irregular because of the same reason as well. So there is something called as hormone replacement therapy. This is given for balancing the hormones. A sudden decrease in hormones will be balanced, and it will be protective for your bone, skin, and heart as well. Because if you're getting menopause at an early age, it might affect your bone and your cardiac health. So, since you don't have any other comorbidities for taking this medication, we can start it and at a lower dose. It's a combination of estrogen and progesterone, and that will help you deal with hot flushes as well. And you can take this for few years till you're adjusted to the menopausal symptoms. Okay, so and there are side effects for any drug, and this drug also comes there are increased chances of clot formation in body. There are also increased chances of getting breast cancer. But the protective effects are that, as I told, it will protect against your bone health, your cardiac health, and it will help relieving your symptoms. And you might have some irregular cycles for first 3 months when you take this medication, but after that it must be okay. And even after 3 months, if you get erratic bleeding, you can come and contact us. Is that okay? So I'll put you in contact with menopausal clinic. And is there any other thing you want to ask?
Yeah, this HRT treatment, whatever you are saying, it is like basically you will be giving some additional harm, that estrogen, whatever you told me, right? But
Yeah.
should I take it? How long should I take it? Like till I get my menopause, or how should it be?
Yeah, till you get your menopause, like at least for 5 years for now at a lower dose, we will start. Is that okay?
Okay.
And I'll be
Yeah.
giving you patient information leaflet for the same. You can read about it, and I'll write back to your GP as well. Okay.
Okay, doctor. Yeah, thanks.
Normally there is a break after 7 tasks. Would you like to take 2 minutes break, or can we continue?
Can I just have some drink and come on? I'll come in 1 or 2 minutes. Yeah.
Yeah. You can once join, we will start. Yeah. Uh, Thank you so much, Valarmati. I know it's the last minute request from us.
Yeah, no problem, doctor. Thanks. Bye.
This conference will now be recorded.
I'm not able to hear the. I think you have to unmute it, ma'am. It's still muted.
Sorry. Yeah. Sorry.
Good morning. I'm Anjana, one of the candidates for today. I'm ready for my structured discussion.
Dr. Anjana, can you tell me what are the possible causes for her symptoms?
This is 60-year-old woman who underwent vaginal hysterectomy, and she has watery discharge. I'd like to ask more about her history. What kind of discharge? Is it post-melding or is it involuntary leak, or and is there any abdominal pain? Is there any other associated vaginal lump or bulge that is felt? And I'll ask her about pain and how is the recovery
Dr.
from the surgery.
Anjana,
Yeah.
from the given information, what are you suspecting in this patient?
It could be a vesicovaginal fistula. Uh,
Okay.
uh, and it could be any physiological watery discharge, or it could be uh, any infection, depending on the type of discharge as well.
Okay. Anything else?
Any diverticulum or
Mm-hmm.
bladder injury.
Okay. How would you assess this patient to reach a diagnosis?
After getting a detailed history and after going through the notes of the patient, what surgery or what complication was seen in the surgery, and after examining her, I'd like to examine her thoroughly. I'd like to see from where the watery discharge is coming from, and what kind of discharge it is, and then take swab from the discharge, and also send it for serum creatinine, and to check whether it's urine that is leaking. We can also fill the bladder and see if with a dye, and see if the dye comes out through the vaginal opening.
Okay. Anything else?
And if I'm suspecting any other injury, we can order for imaging. CT can be done, or cystourethrogram can be done.
Any other investigation you would like to take?
I'd like to take routine investigation as well, like urine routine and urine culture, and abdomen, ultrasound abdomen imaging also.
So this patient was diagnosed with vesicovaginal fistula. Okay, how would you like to manage this case?
I'd explain to the patient that in vaginal hysterectomy there is this complication which can happen. I would explain this as a connection between the vagina and the bladder, and because of that she's leaking urine through her vagina, and I'll I mean, involve the consultant who did the surgery. I'll refer her to a urologist as well to see the condition, and I'll document all my findings, debrief the patients, and I'll raise an incident report as well. And as for the management part, we'll form a team of doctors, and we'll discuss about the surgical correction of the vesicovaginal fistula. See the extent of it, and I'll involve the urologist to correct the fistula.
Okay. Can you just, if you're asked to give a colleague feedback session for this case, can you briefly tell me how would you conduct that?
I will call my colleague, and I'll first inform this case, and I'll greet them. It should be a no blame session. I'll just tell them that everyone would have gone through this phase and everyone are bound to make mistakes. And then I would ask if we faced any difficulty during the surgery, and what happened in the surgery, and is there any additional procedure that was done. So I would ask if it was different from any method, or if any method was found to be wrong. I would tell them politely that this could be better done in the other way in order to avoid future complications. And at the end of the session, we'll discuss what can be done to rectify such a problem in future. And I'll also ask for a feedback session in the reflective session. How the and what he understood or what he learned from the reflective session.
Okay. Would you like to use any props
Uh,
in this case?
Property, ma'am, props.
Yeah. Anything
Uh,
related to this vesicovaginal fistula when you're giving your colleague feedback? Do you want to teach them anything or share your knowledge?
Yeah, we can go through the steps of vaginal hysterectomy and see how each step is done, and see how what instrument is done for holding the pedicles, and what sutures are taken, and what preventive way can be taken for avoiding complications. We can demonstrate it in a mannequin as well.
Dr. Anjana, you have 3 minutes. We will move to the next session, but this will not be like in the exam. Okay, exam you might have to sit for 3 minutes in front of the examiner.
Okay. Okay. Good morning. I'm Dr. Anjana, one of the candidates for today. I'm ready for my structured discussion.
Yes, Dr. Anjana, can you tell what is meant by enhanced recovery?
Enhanced recovery is after post surgery, if a patient satisfies all the criteria for and if the patient is fit and well and the surgery has gone well, and it's a process for discharging the patient on the same day of the surgery that, or earlier than the usual time. So this improves the recovery of the patient and helps her to go into a routine activity earlier.
What are the principles of enhanced recovery?
We have to make sure that the patient is fit for having an enhanced recovery. Like uh, the patient should not be obese. The patient should not be having any comorbidities like
Okay,
that.
now this patient is obese. Her BMI is 40, right?
Yeah.
Will you refuse surgery for her?
No, surgery wouldn't be refused, but we have to post surgery. We have to monitor the patient and see to it recovery process is fine. We can't discharge the patient immediately after the surgery.
Mhm.
So before the surgery, we have to optimize the health of the patient, like by giving iron or iron supplementations to improve the anemia, and discuss a plan of surgery with the surgeons, and early ambulation and early start of use regional anesthesia instead of general anesthesia, and uh, early start of orals when the bowels are opened, and so this will have a good recovery for the patient if we follow certain.
How will you do ER? Can you explain? How do you do enhanced recovery?
Uh, we before the surgery we see if we get a good detailed history of the patient, if and correct whatever comorbidity she has that can affect the surgery. If she is diabetic, we have to optimize the sugar level before the surgery is done. If she is anemic, we need to see if blood transfusion or parenteral iron is required. And before if she's has a kidney disorder, we have to make sure that we have taken opinions from the nephrologist or the particular doctors involved, and and we during the surgery we
See, pre-op, anything else risk factor you want to assess in this patient?
she's a previous three LSCs as well, so there can be chances of additions and multiple organ involvement in the surgery. So that also there are chances for organ damage and injury during the surgery, and that might prevent her from having an enhanced recovery. So multidisciplinary team can be convened, and in the surgery we can ask for experts to help during the if any difficulties are faced during the surgeries.
Any prophylaxis you like to consider pre-op?
Prophylactic antibiotic dose before the skin incision.
Anything else?
Prophylactically, we can arrange for blood cross match,
Mhm.
and
Prophylactic risk assessment.
we can see where the placental location is, and because she has previous 3 cesarean sections, she is at high risk for having placenta previa or placenta accreta. So we have to make sure that the placental location is safe.
Okay. Okay, you continue.
And
During surgery, you were at during surgery.
so during surgery, pre-op antibiotics, type of anesthesia could be spinal has better recovery rate than general anesthesia. So see if spinal anesthesia is okay for her, and optimize her before surgery. We can optimize her weight, put her in a diet in contact with the dietitian, and uh, during surgery, see to that electrocautery is used, and even minor blood vessels and bleeding is stopped, and meticulously we see to it there is no bleeding involved, and mm,
Mhm.
post-operatively we have to assess if her wound is fine, if she requires any antibiotics, early ambulation, and see if her bowels are open, and start her on orals as when her bowels open.
Okay. Anything else you want to do in post-op?
Assess for her venous thromboembolism risk,
Mhm.
and see if she requires heparin.
Mhm.
Put her on low molecular weight heparin for 10 days.
Mhm.
Early rooming in with the baby, breastfeed, and starting early breastfeeding.
Mhm.
See if her hemoglobin is okay, and if not, see if any transfusion or parenteral iron is required post-operatively.
Mhm.
That's all.
Okay. Anything you want to add about enhanced recovery program?
Mm. We inform the patient about this enhanced recovery, and then we generally, if the patient doesn't have any comorbidities, we discharge the patient on same day of surgery if everything is okay. So Good morning, I'm Dr. Anjana, one of the doctors of in labor room today. Can I confirm your name and age, please?
Yes, doctor. I'm Mary Brown. I'm 36 years old.
How do you like me to call you?
You can call me Mary.
Hi, Mary. How are you doing today?
Fine, doctor. I'm having slight leaking through my vagina. It's a watery discharge, so I thought my bag of waters have ruptured, and that's the reason I'm here today.
That's okay, Mary. What do we have here? Is it a boy or a girl?
It's a boy, doctor. I've named him Jerry.
Okay, that's nice. How is Jerry doing today? Is he kicking well?
Yeah.
Okay. Do you have any pain abdomen now, Mary?
No, doctor.
Okay. So, what I want to do is I want to ask you a few questions to know more about this pregnancy. And a recent scan was done. Are you aware of the report, Mary?
No, doctor.
Okay, we'll discuss the report as well. I would like to examine you in presence of a chaperone, and
Mhm.
then I'll discuss a management plan with you. Is that okay?
Yeah, please.
Okay. So, can you tell me, Mary, about this pregnancy? How is this pregnancy so far?
I had no problem, doctor, since the beginning of my pregnancy, and my midwife always used to tell I'm low risk, all my blood tests, everything scanned, still no, everything was normal.
Okay, that's nice. So, what about the last scan, Mary? Was baby head first in the last scan?
No, doctor, it was taken somewhere in the between 20 weeks around that time, and nothing much was discussed about where the head is because they told
Oh,
whatever they're finding now was normal.
okay. So, can you tell me more about your previous two pregnancies? This is
Yes,
your third
yes,
one, right?
yes, doctor. The first one was like it was induced for because I had crossed the dates, and it was a normal vaginal delivery. I did not have any problem. Second one was my home delivery. I suddenly had pain, and my midwife helped me to deliver at home. I was really very happy, to deliver in that atmosphere. And this is my third pregnancy. Actually, I thought I'll have home delivery even this time because last time I was really happy. And my husband also was around here, there. But since the water has broken and I'm not having any pain, I thought I should contact you.
That's okay. That's nice. And do you have any previous medical conditions that we should be aware of?
No, doctor.
Any previous surgeries in the past, Mary?
No,
Okay. Do you have any drug allergy?
no, doctor.
Okay. And uh, whom are you living with right now?
With my husband and my kids.
Okay. How's the support at home, Mary?
It's fine, doctor.
Okay, so what I'll be doing right now is I'll be taking your vitals. I'll be doing a para-abdominal examination to just confirm how the baby is, see the heart rate of the baby, and do a vaginal examination as well to see how your neck of the womb is dilated or whether you're leaking, and other things about the baby. Okay, so I'll examine you. Okay, Mary.
Yes, the examination findings are it's normal for abdomen tummy, it's up to for the term gestation. Fetal heart rate is good. Per vaginal examination, there is no leaking. It was just a excess of vaginal discharge for her. Fetal heart rate is fine.
Okay. Uh, Mary, I have something to discuss with you. The last scan report shows that your baby is not head first, but it is bottoms first.
Oh,
So, do you understand what bottoms first is, Mary?
yes, yes, doctor. One of my friend had the same. The baby head was not coming fast. It was the bottom which was coming. Yeah, I know that. I know bit of it.
Okay, so I'll explain to you about it. In bottoms first, instead of head, the baby's bottom is above the neck of the womb, and such a baby, bottom first baby, when during delivery, it there can be some problems during the delivery of bottoms first baby, and if a patient comes in advanced labor and if the baby is bottom first and if we deliver the baby, there are chances that we need extra manuals for delivery of the baby, and because of that there are chances that baby needs admission to baby doctor's unit as well. There are chances of fractures, or there are chances of injury to the baby. That is, it is a bit complicated than the normal head first delivery. Okay, so
So,
even before,
doctor, you mean that I can't deliver vaginally? It's not safe for my baby?
it's not like that, Mary. The thing is, we have to assess your baby and your pelvis condition. And as for what the scan says, the type of the breach, we call the bottoms first as breach. So the type of the breach is can be suitable for vaginal delivery. The baby's size, the placenta location, everything is suitable, but we need to further evaluate you. We need to see whether your pelvis is adequate. We need to see whether the baby's heart rate CTG graph is fine. And I need to discuss this with my consultant also, and then we can plan. Okay. And before that, there
Doctor?
are one or two
Yeah.
yeah.
Well, my friend, I told you she had a bottom first and they turned her baby head down. Can you not do that for me?
Yeah, I was about to say there are one or two other options. The first thing we might try to do, because you're just now, I mean, when I examined you, your neck of the womb is closed. So one of the things we'll do is try to rotate the baby through the abdomen so that the bottom's first baby becomes head first baby. We call this as external cephalic version. It will be done under a ultrasound guidance. Before that, we'll be seeing the heart rate of the baby, we'll be seeing your mother's pulse rate, vitals, everything, and then if required, we'll be giving you a medication that relaxes the abdomen, and then we'll be trying to turn the baby. But this procedure also has its own risk. There is a small risk that the procedure itself can end up needing for a cesarean section. The baby's heart rate can come down. There is a chance that the procedure can fail. And if you're not in labor and if the procedure fails, we can even attempt it another time if you give consent for it. And then if it's we need to monitor the baby and mother as well after the procedure. If it's fine and if you're not in labor, if we send you home, and we need to make sure that if at all you feel any decrease in movements, or if you feel any bleeding or leaking, you have to come back to us immediately. So these are all the side effects of the external cephalic equation. But the positive point is we can deliver it as a normal vaginal delivery, which has lesser complication than what I told you, a breech delivery or a cesarean section. So if in case this fails, the other option I discussed is breech delivery. And the one more option which will be available to us is going in for a planned cesarean section. So the cesarean section will be better than a breech delivery in complication rate, but it itself as a procedure has its own negatives, or it has its own side effects. It's a surgery, it has anesthetic side effect. If you choose for cesarean section, you will be having a talk with anesthetist to know about what kind of drug will be given to you. And
Doctor, like if I have cesarean section now, we were planning to have one more kid. Can I go for a normal delivery later on?
if you have a cesarean section now, then further pregnancies cannot be, we can't guarantee that it could be a normal delivery. There are chances that the afterbirth in the next pregnancy can attach to the cesarean scar. And there is a possibility, a bigger chance that you might be needing the cesarean section for delivering the other baby as well. So, and apart from that, there are complications of the surgical procedure right now as well. So these are the three options available to you. You can discuss this with your husband. I'll give you some patient information leaflet meanwhile for you to read through it also, and I'll be informing your midwife about the same too. Okay, I'll give you some time for which you can decide and come back to me, and we can go ahead with whatever you decide. Is that okay,
Yes,
Mary?
yes, yes.
Okay.
Yeah. Thank you. There is one more page.
Okay.
One second. Okay, that okay. It's an attached report. I'll show you later.
Good morning. I'm Dr. Anjana, one of the candidates for today. I'm ready for my structured discussion.
Yes, Dr. Anjana, how will you summarize this pregnancy?
This pregnancy is a case of high risk pregnancy. She is gravid 3, paravan live 1, abortion 1 at 9 weeks of gestation. And she has a known case of glomerulonephritis on enalapril and aspirin and multivitamin right now. And she has previous history of one abortion, previous history of gestational diabetes mellitus as well. And uh, making her the fact that she is having she's a case of chronic kidney disease with previous gestational diabetes mellitus with previous miscarriage makes her a high risk pregnancy.
Yeah. What further information you would like to elicit from the patient?
I would like to ask history from the patient, know more about her glomerulonephritis. Apart from these medications, is there anything else she's taking? When was the last time investigations were done, and when was the last time she met with the doctor? And she wanted to get pregnant, whether the desire for pregnancy was discussed with the doctor when she underwent any pre-conceptional counseling, and ask whether she was advised for changing her medication to those which can be taken in pregnancy. Uh, uh, and ask if there was any recent admissions or if there are any symptoms that we should be knowing about. And about previous pregnancies, I'll ask if why the abortion happened, whether it was what was the reason for the abortion, how it was managed, and about the first pregnancy, how a GDM was controlled, whether she was put on any insulin, and how was the recovery from the pregnancy. And I'll ask, apart from this, whether she has any other medical disorders and any other surgical history that we should be knowing of, and any other family history of metabolic disorders, congenital anomalies as well, and any uh, is she a smoker, alcohol, or does she take drugs? It increases the risk further for in the pregnancy. And I'll ask her social history and ask how whom she's living with, and how is the support at home, and how she takes the whole pregnancy right now, whether she's depressed about it, and I'll rule out whether her mental health is okay. And
Okay.
I'll ask for notes
Yeah.
from previous pregnancies and previous CKD treatment as well.
Okay. So what further assessment will you offer her?
So apart from the normal antenatal care, which includes blood test and folic acid and vitamin D, I also want to assess her kidneys further. So I'll go for a multidisciplinary meeting, and I'll before that I'll ask for investigations, RFT, LFT, her complete blood count, her ultrasound to see the kidneys as well, and urine analysis. Whether any presence of cast is there, and is this
Yeah. This is a report.
okay? So. And then I'll check, and apart from this, I'll do a routine antenatal checkup for blood grouping, red blood cell antibodies, and urine routine, and seeing for viral screening. And since she had already got a scan done, I'll go ahead with at 11 weeks. I'll ask for I'll check her blood pressure, and see if you check the urine for protein analysis as well. She's at high risk for developing preeclampsia, so each visit that has to be checked as well. And I'll put her on. She's already on aspirin. I'll stop the enalapirin.
So,
And
Dr. Anjana, right now, what further test other than what is given here? What further test? Any other test you like to do?
Her renal, I'd like to examine her, further check on renal parameters, renal function test,
Yeah.
urine, and ultrasound of kidneys, if any abnormalities there, and in urine analysis, check for any casts.
Okay. So how will you plan her antenatal? Yeah.
Also rule out anemia. She's at high risk for anemia and preeclampsia, so I'll also do tests to rule out both.
Okay. How will you plan her antenatal care?
So right now I'll stop her enalapril, and I'll put her on folic acid, 5 mg, and I'll also aspirin. I'll ask her to continue and assess her venous thromboembolism risk assessment also, and see if she requires heparin, and ask her to continue with vitamin D 10 microgram per day, and I'll call for a multidisciplinary meeting. I'll send her to a nephrologist, and see if her health is optimized right now. Um, and I'll explain to her the risk of the kidney disease on pregnancy, and the pregnancy that can aggravate the kidney disease, and I'll ask if it's a planned or unplanned pregnancy, and what she feels about the pregnancy as well, and after listing out all the risk factors, I would ask what is her opinion about the pregnancy as well. Uh, then after the anomaly scan, I'll offer her down screening, and after that 18 weeks I'll offer her after the dating scan I'll offer her down screening. At 18 weeks I'll offer her anomaly scan. In 20 to 24 weeks uterine artery Doppler, and from the 28 weeks I'll offer her serial growth scans, and to see if there is any IUGR.
Yeah.
And that will be my antenatal care.
Okay. Can you tell about intrapartum and postpartum care of this patient?
Yeah, I'll tell her that this is a high-risk pregnancy. It has to be delivered in hospital and under consultant-led care. As of now, she doesn't have any contraindications for vaginal delivery, but as through the course of the pregnancy, it will be seen, and decision will be taken for a vaginal delivery. For obstetric reason, she can have a cesarean delivery as well, and during her intrapartum period, her blood pressure has to be checked, her renal function test, everything has to be checked, and see if any anemia or further complications of anemia are there, and uh, post and see to it she maintains urine output is also seen in the intrapartum, and postpartum care I'll send her once again for the review with nephrologist. I'll breastfeeding is not contraindicated. I'll see if the medication dosage has to be changed, and I'll tell her about the perineal care, and I'll ask her to monitor her blood BP as well.
How do you monitor the baby?
Serial ultrasound scan. First, I'll do a uterine artery Doppler initially between.
And we are in intrapartum and postpartum care,
Okay.
right? Yeah.
Continuous electronic fetal monitoring will be done, and the baby status will also be seen.
Okay. 2-3 words about how will you counsel her?
I'll counsel her for telling that it's a joint disciplinary meeting, and for her to adhere to the advice of nephrologist, and and that's it. Good morning, I'm Dr. Anjana, one of the doctors in postnatal clinic today. Can I confirm your name and age, please?
Yes, doctor. I'm Anna. I'm 28 years old.
Okay, Anna, you can call me Anjana. So can you tell me how you're feeling today, Anna?
No, doctor, I'm not feeling good. I'm having severe pain in both my breast and I'm unable to feel my son. And
Okay.
this is a very terrible feeling.
I understand, Nana. A postnatal period can be very distressing for some women. Don't worry, we are here to help you out. What I want to do is I'll ask you a few questions to know more about your pregnancy and what happened, and then I'll examine you, and then I'll formulate a management plan which is suitable for you according to your wish. Is that okay?
Yes, doctor.
Yeah. So can right now, how are you? Apart from this breast pain, do you have any other pain, Anna?
I'm slightly constipated, doctor, and that is also causing me slight problem.
Okay. And any other foul smelling discharge or any other pain down below?
No, doctor, no.
Okay. So have you named your kid Anna?
Yeah,
Is it a boy or a girl?
it's a boy, doctor. I've named him Jerry.
Okay. So how is Jerry doing today?
Yeah, he's crying a lot. Maybe he's feeling angry, and I requested one of the midwife to stay with me, and she did not oblige. And I'm really finding it very tough to handle him with this pain.
I understand. Is he? Are you breastfeeding him, Anna? And did you try breastfeeding him?
No, doctor, it's really painful, and one of the doctor told my nipples are cracked. I'm scared that it might infect my son also.
Okay. Are you able to manage with the pain, or shall I right now ask the midwife to give you a painkiller?
They did give me some painkiller, doctor. It is coming down, but
Okay.
it's painful.
Okay. So can you tell me more about your delivery?
It was normal, spontaneous, like doctor, and but in the end, they told they need to use forceps to bring out my son, and that
Okay.
was fine, and I did not have any other problem.
Okay. Was the baby taken to baby doctor's unit after that, or was he
They
shifted?
said everything is fine, and he's with me right from the time of his birth.
Okay. So what about your waterworks, Anna? Is it all fine now?
Yes,
Are you
doctor, I
passing?
don't have any. Yeah,
Okay. So and do you have any other medical comorbidities, Anna?
no, doctor,
Okay. Any previous surgical history?
no.
Okay. And have you whom are you staying with, Anna?
My husband is very supportive, doctor. He's helping me, but he has to look after my daughter also at home, so he's finding it difficult to stay with me here right now.
Okay. So you said you have a daughter, right? So can you tell me about
Yes.
the previous pregnancy? Did you have any such similar pain last time?
No, doctor, I didn't have any problem. Even I did not have problem to breastfeed. I don't know why I'm having this problem this time.
Okay. It's very normal for post-pregnancy women to have such a problem, Anna. Don't worry, we'll look after it. We are here to help you out, okay?
Thank you.
Okay. So apart from this, I just wanted to ask, are you feeling depressed for any other stuff, Anna? Are you feeling like you've
Not
lost?
exactly, doctor. No. Just I'm worried about my son as I'm not able to breastfeed. That's all.
Okay, Anna. So I'll examine you. I'll see your breast as well, and I'll recheck the findings. What midwife had told me, and I'll also see your tummy and see down below, and come back to you. Is that okay? I'll do it in presence of a chaperone, Anna.
Okay,
Is that okay?
doctor. Yeah.
Okay. And from what we examined, what I can see is both your breasts are engorged. Uh, have you heard of this breast engorgement, Anna? Did anyone educate you about this before?
Yeah, the doctor previously who had come, he told that milk has got collected since I'm not feeding my son, and that is causing me this pain.
Yeah, Anna. And one thing is, it's not it's infected. So, but there is also cracked nipples, and this is the reason that you're feeling pain when you're breast trying to breastfeed. Okay,
Mm-hmm.
so what I'll do is I'll put you in contact with lactational counselor also, and
Okay.
and also I'll ask one of the specialist doctors to come and have a look to see that it is not 100% infected, and I'll discuss to you about breast engorgement as well. Is that okay?
Yes, doctor, but I didn't have any problem in my first pregnancy. Why do you think this developed this time?
Each pregnancy for each women might be different, Anna. Like in any pregnancy, a woman can pick up a complication, and this is mainly because your milk is collected inside both the breasts, and that's why this engorgement is there, and we might feel some pain while touching it as well. Is that right, Anna?
Okay, okay.
And but even though I understand that you have a cracked nipple as well, so we'll be giving you some medication cream to apply. What we can do is we can try with some warm compression or cold compression in the beginning, so that might relieve your pain as well as relieve this engorgement, and after that we can try pressing the breast for or pumping the milk out of the breast.
Okay.
Is that okay? In between,
Yeah.
if you have any pain, also we'll take care of it. We'll be giving pain medications, and the lactational counselor will tell you how to support the baby correctly and how to feed the baby correctly as well. Okay, so you can take alternate breast in feeding, and then you make sure that you feed the baby so that this doesn't get collected. Otherwise, it will be the breast. I mean, the milk will be collected in the breast, and it will cause pain, and you won't be feeding the baby. It forms a vicious cycle. So
Doctor, is the medication what they have given? I'm really worried. Is it safe for my baby?
yeah, Anna, it is safe for your baby. So I understand that you will be worried that since the baby is having the breastfeed with the medication, it might affect it, but we generally give prescription that is okay for the baby. Is that okay?
Okay.
Right now, you don't have an abscess, but I'll also tell you what can happen if the collection is not pumped out. It can get infected, and it can form what we call as breast abscess. Then you might have something called that can aggravate and create temperature or fever to the mother. You might feel more unwell, and it can even go up to sepsis. Okay, in those situations where breast abscess is done, we might need to put you on antibiotics, and sometimes we might even call in the surgeon for draining the abscess. Okay,
Okay.
so right now there is no apart from the tenderness, uh, uh, there is no mass felt, Anna. So we'll go ahead with hot and cold compression. Just make sure you keep yourself hygienic and make sure both the breasts are cleaned well, and go ahead and continue with feeding the baby. Is that okay?
Yes, doctor, sure. The only problem for me is like the feeding. Since it's painful, I am unable to feed him.
I understand. I'll also, even though you said you don't feel depressed, I also will put you in contact with some counselors. They will help you even when you're feeling this pain and when you're feeling down, they'll help you come out of it, okay? And when you're okay with all this, Anna, next visit I'll come and discuss you about a contraception plan. Since you have delivered right now, you need to make sure that you give a gap for the next baby if you're planning for one. So we'll discuss about the contraception plan, okay? And I'll give you some patient information leaflets as well regarding the
Thank you.
breast. Yeah,
Thank you.
thank God. Can I go for the next slide?
Anjali, if you stop your control, the Anjana will have a control. She can move around.
She's moving.
Good morning. I'm Dr. Anjana, one of the candidates for today. And today I have labor ward prioritization. And I have two SHOs and six midwives with me, and one on-call consultant in antenatal ward. I'll
Okay,
first
Dr. Anjana. Yeah, go on, go on.
Okay. I'll first prioritize the cases as urgent, semi-urgent, and non-urgent cases. Among the six cases which was given to me, I find that room number 1 and room number 4, I'll classify it as urgent cases, and
Okay.
room number 5 and 6 is semi-urgent, and room number 2 and 3 is non-urgent. Depending on, I'll also examine and then further see what is to be done. First, I'd like to go myself and see this patient in the first room. She's a previous cesarean section 39 weeks. She was examined at 7 o'clock and she was 5 centimeter dilated. She has meconium stain and she's having persistent deceleration lasting for 3 minutes. I would ask, I would check her vitals, see her pulse rate, whether any tachycardia is there, see if she has any scar tenderness. Then do her per-abdomen per-vaginal examination. See uh, if fetal blood sampling is required. I'll inform my consultant about this case and tell that there can be prophylactically prepare her for emergency cesarean section also. I'll inform the anesthetist on call. I'll inform the pediatrician as well, and I'll see if the OT is available. Next. When I'm doing this, I'll send one of the SHOs to room number 4. That's a known case of it's para to 35 weeks, known case of placenta previa with reduced variability. I'll ask the SHO to examine the patient, see her vitals, see if it's stable, if it's put IV line, group, send basic investigation group and save blood for her, and do a CTG and see any other the cause for if there is still reduced variability. To give a shot of betamethasone, and I'll inform this case also to put her in to give oxygen and put her in left lateral position. Before that, I will have to see how much of bleeding is there. If she bleeds more, she might also need emergency cesarean, or and depending on the bleeding, we'll have to either manage her. If it's a major bleed, we'll have to call the anesthetist, manage her, check for her vitals, manage her bleeding first, and simultaneously make arrangement for prepare for the delivery of the baby.
Okay, it's a major placenta previa. Okay, you're supposed to take her for C-section immediately. What precautions will you take?
I'll make sure that the blood is arranged for at least 4 Paxils and FFPs are arranged, and I'll make sure 2 IV lines are there, and IV fluids is going on, and her investigations are taken before that. Her coagulation profile, her CBC, RFT, LFT coagulation profile are done before that. I'll call in before that I'll press the buzzer and I'll call the team. I'll inform the consultant.
Who will do the C-section for this patient?
My consultant will be doing the cesarean section for the patient. I'll inform the baby doctors as well. I'll debrief the patient's relative about the emergency of the situation and shift her for theatre.
Okay.
Put a catheter and monitor a urine output as well.
Okay.
And the second and in second room there is a primary on atosiban. I'll send one of the midwives to go assess the vitals, assess her per abdomen PV examination, see if she's having any contractions, and if at all anything goes wrong, I'll ask her to call me. See if she was given on magnesium sulfate, whether any tocolytics was given, whether steroid was given to the patient, and if tocolytics was given, whether basic.
She's on atosiban. The patient is on atosiban infusion.
Whether magnesium sulfate for neuroprotection is given, and steroid infusion was given to the patient. And in the third room, she's a Jehovah Witness, Grand Multi with 41 weeks. She's actually semi-urgent. Her PV findings also shows that there is not much of a progress. Right now, I'll send one of the midwives to assess the patient, do a ARM. She's 5 centimeter with less progress, and connect a CTG and monitor the baby as well as a mother. And in fifth room, there is a post-delivered patient who has a third-degree perineal tear. I'll inform this case to the consultant. I'll apologize to the patient for coming late because the urgent cases needs first priority. And when I see this patient, I'll check for estimated blood loss, see if any other tears are there. I'll see if mother and relatives are debriefed about it, if everything is documented correctly, and I'll go for perineal tear suturing. And in the last one more SHO, I'll be sending to the patient in emergency. She's 7 weeks with cervix and open and bleeding. I'll ask the SHO to assess the vitals of the patient, do a speculum examination, see the cause for bleeding, and see if she requires any. I'll do ultrasound for her to see if it's any miscarriage. And if it's a ongoing miscarriage, I'll ask her to be shifted to the labor room, and I'll after settling the labor room, I'll be and if the patient's vitals are stable, I'll inform the patient and I'll break the bad news to the patient and the relatives, depending on what the finding from the per abdomen, per vaginal, and ultrasound findings are. I'll deal with the patient.
Anything else in the last case you want to know?
Okay.
Any other information other than scan?
Whether she had taken any other medication or was any I'll also send for investigations like FBC, and I'll group and save the blood, do a cross match, since she can bleed heavily and she might need a blood transfusion later. So
Anything else you like to add to any of the management?
For the first case, I'll make sure that the patient has a IV line. I'll make sure that the blood is taken for group and save. And since the persistent deceleration is lasting for 3 minutes, I will ask consultant to have a look at her and take her for emergency cesarean section as well. And for Jehovah's Witness, I would want to make sure that the consent is taken. Since she's a Jehovah's Witness, she might have objection for blood transfusion, whether the special consent for the objection is taken. And I myself will ask the patient regarding her preference for blood transfusion also. And in case.
You're done, Dr. Anjana. You've finished your 14 cases.
It was very, 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 very. The way we prepare in an exam, the situation is